I would first like to thank the conference organizers for putting this conference together, and thank my faculty mentor for this project, Dr. Marisa Chappelle, as well, for her guidance and support, which has been very, very helpful. I'm also excited to be presenting on this panel with such fantastic presenters as Elsa and Connor. So, that's me. Totally forgot to use that slide. In the summer of 1965, 20-year-old Arlene Isaacson, a college student volunteering with Vista, was shocked with the living conditions for migrant workers and their families. She had tried living in a migrant camp when she had first arrived to volunteer, but had moved out due to the frequent presence of rats and poor sanitation. She stated to the Oregon Journal, "I thought that it would be easy to get adopted. That turned out to be absurd." These conditions for migrants were not uncommon in Oregon. 3 years later, in 1968, Cesar Chavez would call working and living conditions for migratory farm workers in the state among the worst in the nation. A lot of slides. These newspaper clippings, point out two problems for Oregon migrants in this period. Number one, migrant workers and their families experience poor living and working conditions and experience health inequality and barriers. And number two, this combination led to poor health outcomes for migrant families. These health issues were faced across the entirety of the rural United States, which relied on migratory workers, not just Oregon, and were a national problem. And shocking headlines such as these in the 1950s, so 10 years prior, led to national interest in migrant health issues. So the federal government is going to have a response to these concerns. They decided to respond to these concerns in passing of Public Law 87-692 in 1962, which better known as the Migrant Health Act. This act established the Federal Migrant Health Program, which oversaw the administering of migrant health grants to publicly funded programs across all U.S. states. John F. Kennedy takes particular interest in migrant health issues and pushes migrant labor and health reform during his presidency. This excerpt from his book, A Nation of Immigrants, and from Helen Johnson's Help for the Nation's Harvesters, shows two different stances on the motivations for the migrant health program. Kennedy writes, "The people who have come to this country have made America, in the words of one perceptive writer, a heterogeneous race, but a homogeneous nation." Johnson, however, will write, "Our appetites, as well as the farm economy, would suffer if seasonal farm workers, including migrants, were not available to help in the production and harvesting of the nation's crops." So we see two different stories here. They get that the migrant health program, there's the altruistic side, but it's also to provide health care for a vital U.S. labor force. That's why it's created, right? It's not just because of these health issues, there's also labor impact that's very important. So through federal funding and oversight, the Oregon Board of Health creates the Oregon Migrant Health Project to fulfill the state's specific migrant health care needs. The Oregon Migrant Health Project, or I'm going to call it the OMHP for short to save my voice, would run for 8 years from 1963 to 71. To 1971. The major objective of the OMHP was the attainment of diagnostic and treatment services for the migrant worker and his family. Operations began in Mount Herr, Marion, Polk, Yamhill, and Washington counties, and expanded to several counties across the state by 1971. As shown in the slides, we have 12 counties maximum. This is the final year of the Migrant Health Project. The dashed lines are going to be active ones, and then the dotted lines are places with migrant populations that they're surveying in case they would need to expand, but they can't treat them because due to lack of funding. So, skipped over one. There are three main research questions for this presentation. One, what were the population demographics of Oregon migrant workers? Who were these people? Two, what did the OMHP accomplish? And three, what was the OMHP's legacy in Oregon? There we go, that's what I said. This presentation will argue that the Oregon Migrant Health Project, while successful, ended abruptly in 1972 due to shifting government attitudes on migrant health issues and social programs as a whole. Despite intending to be for migrant workers, the majority of patients seen were actually migrant children. That's going to be the second argument. Significance is that the OMHP, as far as we know, has never been studied in depth. It's never had its own research project dedicated to it, even though it's real and I promise you it does exist, real documents. And the migrant health program federally is severely understudied as well. So the research aims to shine light on a social program which has received little scholarly attention. So let's talk about demographics. Who were these people? Statistics from the OMHP annual reports and Oregon annual rural manpower reports show that the Oregon migrant health worker population was mostly 45 years of age and younger. And the elderly made up the minority of individuals in this group. So working age people, children, the elderly in that order. Interstate migrant workers were also the minority of the agricultural workforce. So when we think of migrant workers, we think, oh, they pick all of it. But that's not true during this time period. It's mostly local. Sitting around 70% during this time period, and then 22 to 25% is going to be interstate, so out of state, and then intrastate, often people living in the state who migrate just for the season. For race and ethnicity, 58% of families were Mexican American, 35% were Anglo or white, as they say, and 7% were Indian and Black or African American. They use kind of outdated terms, so if I say Anglo or things like that, I'm directly referencing this project. More families were also choosing to stay in Oregon as their primary residence, or to winter over until the next farm season. So reports increased from 10 families wintering over when the first program started to 450. So more people are staying, more people are becoming residents. So there's also this trend of migrant workers actually decide that they want to live in Oregon more permanently. So after launching in 1963, the OMHP would identify health issues which were unique to migrant workers. So what were these? One, they had poor working conditions. They faced a 300% higher chance of dying from an on-the-job accident than the average American worker. Ronnie Page, a middle-class white Protestant working with migrant ministries during this time, described the brutal conditions which migrant workers were faced with. To see kids with arms twisted out of shape because they'd been broken and left untreated. To see such grinding poverty in the camps. The kids drowning in irrigation ditches. It was the most earth-shaking experience of my life. I became sensitized forever to the social issues of our time. It is important to note that many migrant workers were young, the youngest being around 15 to 16 years old, and I want you to think about that when he's talking about kids, he's probably talking more like later teens, so 17 to 20. Poor living conditions. So the press is going to dub these rural ghettos due to how bad they are. So in an August 10th, 1965 issue of the Oregon Journal, the reporter will state, "I stood in a migrant camp near here and simply couldn't believe my eyes. All around me there was squalor, scattered debris, garbage, animal excrement, dust." The reporter also detailed the condition of the home itself, describing the houses as ramshackle, ready to topple, and lacking complete roofs or ceilings. One migrant interviewed stated that as soon as their family could, they were going back to California. She stated, "We can't get any medical attention here." The two newspapers I have on the right were the Oregon Public's window into the life of migrants. However, I will say it's rare to find these on the front page. They're usually near the back. As you see with that OMHP launch, there's a little stake ad there, so you can see that we're hitting the advertisement section right there. Number 3, poor pediatric health. Pediatric health was a severe major concern for the OMHP. Infant mortality for farm worker families was 125% higher than for other Americans. In fact, the Migrant Health Project saw mostly pediatric patients, around 66% of all patients seen compared to the approximately 27 to 29% aged 17 to 25. To address pediatric issues, the OMHP ran pediatric clinics during the peak agricultural season to treat children and provide care advice to mothers. We can see this in the following images from OMHP records, where a pediatrician is performing a physical exam on the top, and then we see a Spanish-speaking nurse is providing health counseling. And I want to point attention to that multicultural demographic aspect. So here we have a picture. I hope all of you can see it. I'm sorry if the light is shining, but we can see really quite a big diversity of kids in the one particular camp that they photographed while they're waiting to get health education. I think it really drives home the point that in Oregon, it's very unique that these camps would have so many different types of people during this time period. So accomplishments. The OMHP's major accomplishment would be the sanitization of the rural ghettos, which migrant workers lived in. Migrant camp sanitation from 1964 to 69 increases from 18.6% to 57.7%, with camps with excellent to very good living conditions. And the very poor ones decreased from 47.2% to 14.1%. So they're gonna take a general survey in 64 and they're gonna find that most migrant camps are actually extremely poor living conditions. What does that mean? There's no running water or the water's contaminated. Really think about that article I just told you about the animal excrement and the dust. And that was the commonplace before they intervened, and they really had great, really successful programs. They also had medical, dental, oh my God, and mental health services for migrants. So it was a comprehensive care system. Unless you had to go to a specialist, then you would often have to pay out of pocket. And they also used a lot of effective mobilization of student volunteers. So see, this is actually an OHSU, formerly UO, School of Medicine, or School of Dentistry, dental student. He's teaching these kids proper oral hygiene. So the OMHP is going to end very abruptly. In the last year, it struggled due to the diversion of federal funds. In 1971, the program director opened the report by discussing illegal withholding of funding, possibly tied with Nixon's cutting of welfare programs, or could be due to an amendment of the Migrant Health Act, which was made in 1970, which I don't know yet what that amendment was, but I know it happened. The OMHP does not publish more reports after this, indicating that the program was terminated. The federal migrant health program would be completely restructured in 1975 to just provide grants rather than directly administering its own health program. So what we know today is the Migrant Health Act. It's going to go into this block grant system, and we're going to get rid of the direct government administration. So I want to talk about the legacy of the OMHP. While it did do good, these underlying health problems did not go away. Migrants still had difficulty in accessing quality health care. To hammer this point, I'd like to briefly finish by discussing Virginia Garcia, a 6-year-old Tejano migrant who came with her family for the strawberry harvest in 1975. You may be familiar with the name from the clinics if you're from Yamhill and Washington counties. But Virginia Garcia was, in fact, a very real person. Before the clinic existed, she was real, and the clinic is named after her. In June 1975, Virginia Garcia is going to die from septicemia due to a poorly treated foot wound, again at 6 years old. She received this wound from stepping on a rusty nail along the way to Oregon, and her family did not seek care for her until it was too late. She was denied emergency care at a community hospital due to lacking insurance. And by the time she arrived at St. Vincent's, who would treat her for free, it was too late and she passed away there. This case, while it did lead to the creation of the Virginia Garcia Memorial Health Center, which does combat migrant health issues, points out that these health problems remained unresolved 4 years after the OMHP had ended and beyond. Her death was and still is tragic because it was preventable if she had proper health care. While the outlook for migrant health has improved since the 1970s, these health inequalities still exist into the modern day and must be taken seriously. Health barriers have sinister consequences, and in Virginia Garcia's case, that consequence was her death. On a more cheery note, in conclusion, sorry, that's a rough transition. In summary, the OMHP was a profound welfare program which offered crucial healthcare services for migrant families. While initially intended to serve mostly the migrant worker, their children became the main priority for the OMHP, as they were the most at risk for becoming ill. For methodologies, the OMHP annual reports and Oregon State annual rural manpower reports were used as a primary source to collect the population and health data for this project, and I cross-referenced them. For future directions in this features, I am trying to hunt down the missing annual reports for the OMHP. There are 3 years missing. It's quite frustrating. But what we do have is still quite comprehensive, and I'm still trying to figure out what that sharing of federal and state authority looked like, because it was federally administered but state run, and there was a lot of crossover between the two. Thank you.